Good morning, everyone. Today, I'm starting this new podcast series. The title is Meaningful Conversations in Psychiatry. And I'm extremely honored because I have someone with me who I think not many will not know in the field of psychiatry, psychology, and neuroscience. Without further ado, I would introduce Dr. Alan Francis, who was the psychiatry chair at Duke Behavioral Health in North Carolina. He was also the chairman of task committee for DSM-4. He has written books. One of them is Twilight of Insanity, which he published in 2017. Uh, Good morning and welcome, Dr. Francis.
Well, good morning to you and good luck with your series.
Thanks a lot. I think that my first guest is you, so it has set the bar so high that I would have difficulty inviting people, but I will try my best. Uh, so, Dr. Francis, how are you doing today?
Very good.
Okay. Uh, and I have known, of course, Dr. Francis, I have read about and all that. I do feel there are things in psychiatry which may not be working the way they should. And I think that Dr. Francis, we would be asking him questions which some people have sent me. I have myself a lot of questions. And I think I personally feel from what he writes that there are some things that he also feels that may not be going the way they should. So we'll start with the first question, which many people sent me, is that what is your opinion about DSM-5 and the DSM-5 TR as a whole,
Our
generally?
major goal with DSM-4 was to hold the line on overdiagnosis. The DSM-3 was a very inclusive system. DSM-3R, TR even more inclusive.
Mhm,
We had 94 suggestions for new diagnoses, and we only included two of them. One was Asperger's,
mhm,
and the other was bipolar 2. We had good reasons for including both, but they both led to fad diagnoses. That
mhm,
any time you add a possible uh, misuse of the DSM system by including a new diagnosis, it will be misused. And
mhm,
even though we've done careful field trials that we had very good reasons for including these two out of 94 diagnoses, they just exploded in the rates of misdiagnosis, of overdiagnosis. So I was very much against DSM-5 because it had the exact opposite attitude that we had in DSM-4. We were conservative.
mhm,
DSM-5 said it's a blank slate. If you like a new diagnosis, include it. There was very little critical thinking about
mhm,
unintended consequences. And I've never met an expert who didn't love their own diagnosis, their new suggestions.
mhm,
Experts will always be expanding the system, and you need them as important consultants in the project, but they shouldn't be calling the final shots. And what DSM-5 did was allow experts to add many new diagnoses. So I've been cautioning people last 15 years to use the system with care, to underdiagnose rather than overdiagnose,
mhm.
to be very cautious before making a diagnosis. You can't make a diagnosis in 15 minutes. It requires really knowing the patient.
Absolutely.
80% of diagnosis is done by primary care doctors, often after a very brief visit with
Mhm,
patients they don't know, often leading to medication that may not be necessary. So
mhm,
my plea in this podcast would be that use the diagnostic system carefully,
mhm,
write your diagnoses in pencil, not in stone. Be
mhm.
very cautious in making a diagnosis, that it's easy to upgrade a diagnosis. Once you give it, it's very hard to remove it, and people can be haunted by the label for the rest of their lives.
I think you make such an excellent point, Dr. Francis, that it is always, I always feel it's like adding salt to the food. That if you have less salt, you can always add it. But if it's over salty, there's nothing you can do to remove that. And being an inpatient psychiatrist, I cannot agree more with that. Like we get patients from outside facility, from our own, and there are like 20 psychiatric diagnoses. It's a polypharmacy regimen. They are on couple of antipsychotic, two more stabilizers, benzos, and all that. And when you start talking to them, the by that time, some of them has internalized those diagnoses, but if you get collateral information, you start making a timeline of the symptoms. At the end of the day, they may end up with like two or three diagnoses, but because they have been carrying those diagnoses for such a long time, now it's so difficult to undo. It's so difficult for us, for someone like me, to convince them you may not have it. So one thing I'll ask you about DSM-5. So uh, it's not like a scientific thing which people say, but like a conversation which I have heard from a lot of people that up till DSM-4, when people like you and all that, the diagnoses were research based. It was clinical, it was research based. But in DSM-5, it felt to people that they were a group of folks that sat together and thought this is okay to include, and that's how they did, with little research or clinical background for those diagnoses.
Well, we have to admit that there's very little compelling research in the whole area of diagnosis. That DSM-3 was based on consensus methods of people, experts gathering in rooms and shouting what they thought was the best idea, and whoever was most stubborn and most senior often got their way. That we tried with DSM-4 to be much more research-based in an effort to stabilize the system, and we had careful reviews of the literature. We reanalyzed data sets. We did careful field trials, and even that didn't work to stem additional fad diagnoses. With DSM-5, there was a kind of low threshold for inclusion of, of new diagnoses. And I think what we have to understand is that for the most part, there is not compelling evidence to add new diagnoses. The desire to do so usually comes from researchers in the field, but that once and those researchers usually have almost no experience with regular clinical psychiatry or with
Exactly.
how diagnoses are used in the real world. They work in research clinics. The patients are carefully evaluated, highly selected before they get to the clinic. But the diagnostic system, 80% of the diagnoses made and the treatments given, which is medication treatment, primary care doctors. The
Absolutely.
generalization from a research psychiatry clinic, which is highly, highly specific and very intense in the evaluation, to primary care or to primary psychiatric care is just very poor. And something that might work for the researchers will be a disaster in general practice. The other point you made is crucially important. What's happened partly because psychiatrists get to spend way too little time with patients.
Mhm.
They make snap diagnoses, often inaccurate, often unstable, often unreliable. But once the diagnosis is on the chart, it carries a life of its own. I
Yep.
think it's very important when you're doing your evaluation of a new patient to know the diagnoses on the chart. You have to get the chart. You have to speak, if you possibly can, to previous clinicians.
Mhm.
But don't necessarily have to believe everything that's on the chart. And when patients have three or four or five diagnoses that have been given over time by different clinicians, usually carelessly after very brief evaluations, you can assume that many of those diagnoses are wrong. The most common offender now is ADHD, which is
Yep.
attention problems and hyperactivity are ubiquitous across all psychiatric diagnoses.
Mhm.
Every single psychiatric diagnosis can affect concentration and activity. And what's happening now is instead of ADHD being reserved for the small group of people for whom the diagnosis makes sense, who have a very early onset and classic symptoms of ADHD from childhood, it's
Mhm.
being given to adults with every psychiatric disorder as an add on. This is absolutely disastrous because it means some people are getting stimulant drugs who have bipolar disorder.
Absolutely. And I, when I was in med school in Pakistan, and even there was a trend that medical students, engineering students, highly competitive studies, they sometimes would like abuse stimulant to pass the exams to enhance their concentration. And personally feel like what you said is if someone did not have significant ADHD symptoms starting from childhood during that time, you get collateral information. You maybe if you have to, you go and ask the teachers, the parents. How can someone develop out of nowhere in their late teens or in their 20s and even in their 30s ADHD symptoms? And now those people are on stimulants one after another, and those stimulants are not only interacting with their other psychiatric medication, it is causing tachycardia, it's causing insomnia, and then you are putting them on Ambiens, the hypnotics. So it's one thing after another. I personally believe that what they call adult onset ADHD, I personally feel it's a sham diagnosis. It's possible that it was in childhood, was not diagnosed, but when people call adult onset ADHD, I believe it to be untrue, except for two conditions. That is, someone developed a TBI, that's a structural change, or there's a long history of stimulant abuse like methamphetamine that like literally changes your structure of your brain. Dr. Francis, what's your opinion on this thing which they call adult onset ADHD?
Adult onset ADHD is not an official diagnosis, even in DSM-5.
Yeah.
DSM-5 allows you to make the diagnosis if there was an onset before the age of 12, and DSM-4 is before the age of 6. And
Mhm.
I think people should be very cautious. The diagnosis of ADHD should not be given for people who have adult onset hyperactivity or adult onset problems with concentration. The first thing you should do is a careful differential diagnosis. Are these symptoms being caused by another psychiatric condition, which almost always they are? Are
Yes.
they being caused by substance use? Are they being caused by a medical or neurological problem? And instead, what we have is this wild overdiagnosis of ADHD. We have a wild overdiagnosis of autism. And the tendency at this point is to, on the basis of a 15-minute interview, to throw in a new diagnosis that may never be changed, that may
Yes.
dramatically affect a person's life. It should be as important as buying a house to get a
Mhm.
diagnosis. It can have that kind of impact on a person's life. And now the tendency is to give out diagnoses fairly promiscuously, very carelessly, and after knowing the patient for 10, 15, 20 minutes. Primary care
Absolutely.
doctors are in the worst position here, but a lot of psychiatrists at this point are seeing patients for very short periods of
Mhm.
time. And it's
Yeah.
important not to be causing more harm than good by adding on diagnoses that may be very inaccurate, very stigmatizing, may lead to medication treatment that goes on for decades,
Mhm.
all after a very brief evaluation with very limited information. The other thing to realize is that the time you're seeing the patient is likely to be one of the worst days in their life,
Exactly.
certainly for inpatients. So you're
Exactly.
seeing them on the worst day of their life. But in general, psychiatric patients are not appearing at their best.
Mhm.
And many of the symptoms you see are transient symptoms that shouldn't be given the dignity of providing the basis of a lifelong diagnosis based on how the patient is at their very first moment, worst moment.
100%. And I think I trained at University of North Dakota, and one of the good things about some of the our supervisors there is exactly they used to say that, especially on inpatient floor, you're seeing someone who is at his or her best, likely, and then you put labels. My program director used to say that if you misdiagnose someone with bipolar disorder and put that person on, let's say, Depakote. Now that's an anti-epileptic. You put someone on that. Now, who would take that person off? Like taking anyone off an anti-epileptic itself causes a risk of like just like seizures possibly. So that it's such a dangerous situations that medications, antipsychotics, mood stabilizers, they are being offered to patients with little research about their diagnosis, and once they start taking it, it just gets stuck to them, and then no one would dare to like change it or take them off because it's too risky.
Well, I think that one of the things that was unrecognized for too long and is only recently being emphasized is the fact that virtually all psychiatric drugs have withdrawal syndromes, not
Hmm.
necessarily in every patient, but
Hmm.
often enough. And when a patient gets symptoms as they stop or reduce the medication, they often misattribute those symptoms to a relapse of the original condition
Hmm.
rather than withdrawal from the medication. It's one of the reasons people stay on medication way longer than they need to, with all the complications and side effects that can come with that, because when they try to stop, they have symptoms. It is the easiest thing in the world to prescribe, too easy. It's
Yes.
very difficult and requires great skill to deprescribe.
Hmm.
Fortunately, lately, the attention to deprescribing has led to guidelines, to a much greater education of clinicians and of patients about the importance of not stopping medicine suddenly. Even if the medicine's the wrong medicine, it shouldn't be stopped suddenly because there can be withdrawal symptoms.
Exactly. So what I was told that if someone is has been on benzodiazepine, irrespective of diagnosis, for 5, 6 years, or even 10 years, it may take a year, at least a year, to taper them off safely.
Yeah, benzodiazepines are a tremendous mistake in psychiatry. That they're appealing. They work quickly.
Hmm.
Patients like them. But once on a benzodiazepine, it can be difficult and sometimes impossible to get off them. That the deprescribing of benzodiazepines is the most delicate, partly because the complications of the withdrawal symptoms are the most
Hmm.
severe, and they have really no indication in psychiatry. The only possible indications that make sense are for patients who have catatonia, but they're very rare.
Yes.
Acute use in emergency rooms and sometimes on inpatient services.
Hmm.
The routine prescription of benzodiazepine, something like 4% of Americans are on a
Hmm.
benzodiazepine, and 8% of elderly. In the elderly, benzodiazepines are an absolute disaster because
Yes.
they affect memory and they can are risk factors for falls. We
Exactly.
have an easy tendency, especially in primary care. 90% of
Hmm.
benzodiazepines in the US are prescribed by primary care doctors who don't know the risks that they're creating for their patients. I don't see, for the average psychiatrist, I think could go through their entire career and never prescribe a benzodiazepine. I
Yep.
think people in emergency rooms, it makes sense, and inpatient services, it may make sense in an acute way for very agitated patients. But by and large, aside from catatonia and for that kind of acute agitation, there's no clear indication. We should not be having 4 to 8% of our population on benzodiazepines.
And
But the caution is no one should stop them on their own,
exactly.
and doctors should do it very, very gradually.
Exactly. And I think the other thing is, which is even more dangerous, that often we see patients who are on more than one benzodiazepine at the same time. I have seen that, and I cannot say that I see it very less often. It is becoming more and more frequent that they are on two benzodiazepine, or one benzodiazepine and one Z hypnotic and then one opioid. So it's a pretty dangerous combination.
Yeah, it turns out that about 25% of people who die in fentanyl overdoses are also on a benzodiazepine. That they
Oh.
become so ubiquitous, they don't kill on their own, but they're adjunctive killers
Mm.
with other medications, particularly fentanyl. So the widespread use of benzodiazepines that has them sort of so available, so
Mm.
ubiquitously available in the population is really dangerous. You bring up another important point. Polypharmacy is now ubiquitous
Mm.
and completely unsupported by evidence.
Mm.
Hard enough to compare one med to another med. It's impossible to compare two meds to one med. You don't see any studies of
Mm.
polypharmacy because it gets methodologically too difficult. The ends have to be too large. And so what we have now, and psychiatrists are very much partly to blame for this. What we have now is the typical patient coming to your inpatient service, as you mentioned, may be on 4 or 5 drugs.
Mm.
They may have been on these for varying lengths of time. Drugs get added and are never sunsetted. You get additive side effects often without getting additive benefits.
Mm.
And so the entire practice now of psychiatric medication has gotten wildly out of hand, and people are on medicines they definitely don't need, but
Mm.
have trouble stopping. It's very important not to be starting many drugs at one time.
Mm.
Very important when drugs don't work, not to just add something to a regimen that hasn't worked, but to gradually be sunsetting,
Mm.
being mindful of the need for slow deprescribing, sunsetting drugs that don't work as you add new drugs to see if they do work. And instead, the general practice in the field has become just add new things, throw them in as if side effects and complications don't matter. And patients often, the first thing I think about when I see a new patient is drug side effect.
Absolutely.
Before thinking of any other diagnosis, I think the three things that always have to be thought of with every patient are medical and neurological problem. Rule that out with every patient. Substance abuse,
Yes.
and the third thing would be drug side effect. And particularly in elderly patients, drug side effect is overwhelmingly the cause of new symptoms and
Absolutely.
often missed. And what happens is, as we said before, is that the side effect is chased with yet another medication
Yes.
that adds on to the overall burden of complications and side effects from medication, rather than thinking that stopping a medication. I've had more patients, especially elderly patients, benefit from stopping medications, from deprescribing, than by prescribing something new.
Yeah, and I think what I have noticed, especially in the new residents, interns coming, what I have noticed is there's like a knee-jerk reaction. Patient tells you a complaint and you feel obligated to give a medication for that complaint. It's just like putting a band-aid instead of finding out what is the reason of that complaint. Like, for example, one example I always tell my residents is insomnia is like one of the most common complaints in outpatient psych clinic or even inpatient. What I have seen where I got trained, we have a good sleep clinic. So what I do is I often ask them questions about obstructive sleep apnea. And roughly in my practice, 30-40% people actually have it. And then they keep on giving them medication, benzos, Z hypnotics, and all those medications, and they will still say I cannot stay asleep. And once they do the sleep study, they have sleep apnea, they get the CPAP, and it's better like this. So this is like one of the main thing that you need to ask them questions. Is it difficulty falling asleep or staying asleep? Why are you getting up? So these are small things. I think that the residency structure itself, there's so much rush about seeing patients and charting and all that, that the basic core of the field of psychiatry, which is spending time with the patient, that has is going away.
Hippocrates, 2,500 years ago, said it's more important to know the patient who has the disease than the disease the patient has. And now it's gotten to the point where many clinicians are treating individual symptoms with a separate medication, not just treating a disease,
Mhm.
missing the patient, but treating individual symptoms, missing the disease and certainly missing the patients. For mild to moderate problems across the board, uh, the first reflex should not be medication.
Mhm.
Very often, the first reflex to get the patient out of the office, especially again in primary care, is give a pill for every problem.
Mhm.
For mild to moderate problems, watchful waiting is a wonderful solution because, again, you're seeing people on their worst day, and 2 weeks later, they're going to look very different. And
Mhm.
many people get the medication on the first day, misattribute the improvement they experience in the next 2 weeks to the medication, when really it was just tincture of time. The time is a great healer when you're seeing people who are suffering. They will look different without medication. Watchful waiting is perhaps the most powerful underused tool in our field. Psychotherapy for mild to moderate problems is just as effective and much more enduring and has fewer side effects than
Mhm.
medication. So that if people aren't presenting with urgent, severe problems, the first step should be watching for time. The second step should be psychotherapy. Medication shouldn't be a first instinct. It shouldn't be just what I do. I see a patient, I write a script. Medication should be a last resort for people with mild to moderate problems that are more transient. Medication is essential for severe problems. Medication, or in the case of depression and mood disorders, is crucial for severe problems. ECT is important
Mhm.
in treating mood disorders for severe problems. People with severe problems do not have a placebo effect, usually do not get better with time.
Mhm.
and they need medication. Psychotherapy may be adjunctive, but not primary.
Mhm.
But we have the current situation where people with mild to moderate problems are getting way too much medication, way too little watchful waiting in psychotherapy. People with severe problems are horribly neglected in this country. There aren't nearly enough outpatient services.
Mhm.
There aren't nearly enough inpatient beds. We have something like 300,000 mentally ill homeless because there's
Yes.
no treatment available, almost an equal number of mentally ill in prisons
Mhm.
because it's easier for police to bring them to jail than to an
Mhm.
emergency room when
Mhm.
they know there'll be no bed, there'll be no outpatient,
Mhm.
meaningful outpatient intervention. So we're terribly neglecting the people who could greatly benefit from medication. At the same time, we're way over treating people who do better without it.
Absolutely. Dr. Francis, my next question is the alternate model for personality disorders. I think that has been under discussion for a while, where people say that instead of like putting a diagnosis of personality disorder, you could say that, okay, that person has few traits of borderline, few traits of dependent, few traits of narcissistic, as compared to just saying, okay, that person has a borderline, that person has an antisocial. What's your opinion about this?
Well, I wrote the final section of the DSM-3 personality disorder section in the late 70s, and a paper in the early 80s and talks in the early 80s said that dimensional systems were much more accurate than categorical systems of personality because personality is not present or absent. The
Mhm.
personality features are on a continuum from normal personality features to those that cause great problems. There's no clear boundary. And they also lapse into each other. There's not a clear
Mhm.
boundary between one personality disorder and another, and also not a clear boundary between personality disorders and what we used to call axis one conditions, the
Mhm.
other psychiatric disorders. So in 82, I think it was, I wrote a paper that pros and cons of uh, dimensional versus categorical systems on personality disorder. In 94, at the end of, we tried to get a dimensional system into DSM-4. It turned out that the people involved in this could not agree on what dimensional system to use. And we realized that it was very complicated for clinicians, that people tend to think in names. Human beings think in names. Computers think in numbers. So
Mhm.
long as clinicians are doing diagnosis, they will have trouble using a dimensional system. Once computers take over, which is going to be very soon, for much of diagnosis and treatment, they will much prefer numbers, and dimensional systems will become very popular. But we wrote a paper in 1994 saying dimensional systems, not whether, but when, wondering when it would become possible to use them. A dimensional system was suggested for DSM-5, way too complicated, not usable.
Mhm.
ICD has tried one, but I don't think it works very well. I think that dimensional systems of personality will become very popular when computers do most of the diagnosis. And the way things are going, it's kind of scary. I think computers will be replacing a
Mhm.
lot of us in the field of mental health, maybe replacing a lot of people everywhere in every type of job description. But computers will be able to process the complexity of numbers, and it's a much more accurate way of doing diagnosis. But it's completely unusable, I think, by average clinicians at this point.
Absolutely. And then, of course, one of the topic you often see me and I see you and other people talk about on social media as well, the anti-psychiatry. Uh, and I see, of course, I have been observing it, see both sides of the arguments. What I would like to ask is that when they say that psychiatric illnesses don't exist, of course, we know the chemical imbalance theory would happen and all that. What's your opinion when they say, oh, they're not medical illnesses, they don't exist, it's just the circumstances?
Well, it's a complicated question. I like to discuss this in terms of three umpires. The first umpire says there are balls and there are strikes, and I call them as they are.
Hmm.
He believes he's seeing the world straight on. The second umpire says there are balls and there are strikes, and I call them as I see them. He's saying that we see the world a certain way and we form constructs that are useful in seeing the world, but we don't necessarily see the world straight on as it is.
Hmm.
The third umpire says there are no balls and no strikes until I call them. as if all of the ways we see the world are made up inside our individual perceptions and cognitions, and that there's no truth at all. I think the first umpire is a naive realist, and a lot of the people in psychiatry have had the belief that what's in the DSM really expresses what's really in the field, and that's just not true. The DSM categories are constructs. The patients don't follow the book as clearly as the naive realist thinks they do. Patients present with symptoms that are at the fuzzy boundary between disorders. The schizophrenia is not going to be one disorder. It's going to be 100 different disorders as we learn more about it. That the complexity of human beings, the complexity of the brain environmental interactions, all of this means that we will not have simple answers, that schizophrenia is not a simple disease in the way that some people think of it. On the other hand, it's not something made up. Thomas Szasz wrote a book called The Myth of Mental Illness, as if things were just made up. People who meet the criteria for schizophrenia have a fairly homogeneous course, have certain treatments that work. For differential diagnosis, it's crucial that we use these constructs and not assume that everything is a myth or that all problems are caused by trauma. I think we have to take a broad biopsychosocial view of mental disorders. They're not caused by just biology. They're not caused by just psychology. They're not caused just by social environment. It's a very complex interaction of all of these. Treatment requires that you think of all three factors and even adding a spiritual factor to help people find meaning in their lives. And anyone who thinks that there's a simple truth to explain the complexity of psychiatric disorder is just simply wrong. So I have no faith at all in people who worship the DSM as a Bible. I have no faith at all in people who say, well, I don't have to use it at all. I only trust clinicians who realize that it's a limited and fallible document, but a useful one, and particularly helpful in differential diagnosis to ensure that the problems are not caused by medical issues, neurological issues, drug abuse, medication side effect, to be aware of the fact that the different disorders, although they're not pure cases, although there are fuzzy boundaries and they're heterogeneous, do provide a very useful source of communication and also of treatment planning and a way of discussing problems with patients. So the anti-psychiatrists who say psychiatry is just nonsense do a disservice to patients. The people who defend psychiatry, even when it goes beyond its limitations and makes claims like chemical imbalance that make no sense or make little sense, that I don't trust extremists, that this is a complex field. Mencken said 100 years ago, for every complex problem, there's a simple answer and it's wrong. And that's particularly true in psychiatry.
Absolutely. No, and absolutely. And yeah, I agree. Especially, I think I agree, people have been harmed with medications. The informed consent, the way it should have been done, it was not perhaps done. What I see as an inpatient psychiatrist, also but do some outpatient, is that as a clinician, when you see like a floridly psychotic patient, presenting no drug use, and you get history, the symptoms have been worsening, or a floridly manic patient, that is something that how can I say that does not exist and this is just circumstances, because that is so severe in front of your eyes. Once you see, you cannot unsee it.
Well, most of the anti-psychiatrists and most of the critical psychologists and psychiatrists have not worked with severely ill patients.
Mhm.
Thomas Szasz was a great example of this. Tom Szasz wrote the book, The Myth of Mental Illness, in 1961. And I had dinner with him in 1977. And I asked him, if your child were psychotic and suicidal, would you intervene? And he looked at me with a little smile on his face and he said, Alan, I'm a father first and a libertarian second. Even Thomas Szasz was more reasonable than the people who follow him slavishly. The Szazians are more rigid than Tom Szasz himself ever was. I think that people jump at diagnoses too soon. So if I see that person as a young adult who's having a florid psychotic episode, I don't know what that means. At the
Mm,
age of 18 or 19,
mm,
the future course of that florid psychotic episode could take many different paths and have many different long-term treatments. So I'll be very cautious about, I won't call them schizophrenic
mhm.
first psychotic episode.
Absolutely.
I will be focusing on the symptoms now with a very cautious long-term prognosis. We won't know whether this is going to be one episode in a college kid that will never happen again, whether this happened because of drugs, whether this happened because of head trauma.
Mhm,
We have to be very cautious in making diagnoses early in the patient's career. Things settle down over time and you can get a clearer idea.
mhm.
But I think the main point is that psychiatric illness, if we call it that, causes great suffering. It causes
Yes.
great suffering to the patient. It causes great suffering to the parents and the
Mhm,
other family members. It causes great suffering to our society. It's a terrible social problem that we have
mhm,
so many people who need treatment in jail and on the streets. We
mhm.
have to recognize it. We can't neglect it. We can't make um, it seem like it'll go away because we say it should go away because everything is due to trauma or everything is due to this theory or
Mhm.
that theory. We're dealing with complex human phenomenon with very important consequences. We have a great deal of knowledge about how best to treat people. There's a lot we don't know. We
Mhm.
should be applying what we do know as well as we possibly can and admitting what we don't.
Absolutely. And my last couple of questions would be, so one of them is about the underuse of ECT and modalities like clozapine. Very close to my heart. I've been trying to advocate for that. What's your take on the underuse first, like ECT, because that is also like one of the biggest target of anti-psych, and then of course clozapine.
Yeah, there have been very few good studies of ECT because it's impossible to study really. That the
Yeah.
people who most need it can't sign informed consent.
Mhm.
It's often urgent treatment that has to be done quickly. The informed consent for research, they can sign informed consent for clinical treatment. The point here is that anyone who's worked with severely ill people and who's seen ECT in action is amazed by how effective it is in people where nothing else has worked
Mhm.
and much safer in many ways than medication. So ECT is for the very rare patient who doesn't respond to other problems, other treatments, will never be a placebo responder, who is incapacitated by very severe symptoms of depression and agitation and suicide feelings, or very acute mania that's not responding to anything. ECT is not a treatment given often, but for some people, it's absolutely life-saving, and it is the most effective treatment in psychiatry. It works fast. It has a dramatic effect, and for some people, it's the only thing that works. No one should say ECT is a treatment that should be given lightly, but no one should say it's a treatment that should be outlawed, as many antipsychiatrists do. Clozapine is the only antipsychotic drug that works better than the others.
Mhm.
So most antipsychotic drugs are me too in their effectiveness. They just have different side effects.
Mhm.
Clozapine, which is not an easy drug to give because of side effects and complications, is more effective, does work with patients who are resistant to all other antipsychotics, is terrifically underused in the United States, especially. Why is it underused here? Because we neglect severely ill patients. We don't have clozapine clinics.
Mhm.
Medication is best given by people who know how to use it
Mhm.
and requires more attention to clinical care and side effects and complications than most medicines. But for certain patients, it's absolutely wonderful and life-saving. Improves their functioning dramatically. And I think that part of it is our lack of training in how to use it. So most people go through residency training, never treating a patient with clozapine.
Exactly, exactly.
A lot of laziness on the part of clinicians that because it's more difficult to give, requires more blood testing,
Mhm.
requires more attention. A lot of clinicians are afraid of it or too lazy to learn how to use it.
Mhm.
We need systematic availability of clozapine. And I think if we had it, we will have many fewer people in prison with psychiatric
Mhm.
disorder, many fewer people homeless.
And I think you made a really good point, clozapine clinic. I think there's no data, but I think not more than 10 to 15 psych residency program in USF clinics. I was lucky enough. University of North Dakota had one. They built it on, I think, the pattern of University of Minnesota. And then, of course, Harvard and Hopkins. I think what I have seen working with the residents is that most of them, they do not work, their primary site of rotation is not like a state hospital or like a state-sponsored outpatient facility because most of the patient on clozapine, they will end up either in a state hospital or they would be in a PAC team, ACT team, stuff like that. So you're absolutely right. They spend 4 years of residency without initiation. They never start someone on clozapine. They don't know what things are required in order to start someone, how to manage, how to increase the dose, how to manage the potential side effects, what to do if the neutrophil counts go down. And I think we have been raising this point at so many levels that clozapine clinics is like a need of hour, but I think still there's a long way to go. Maybe with this FDA advisory committee, if they start doing that and modify RAMs or
You
just
mentioned that every clinician, I don't think any psychiatrist could feel they're a competent clinician if they can't prescribe clozapine.
absolutely.
I think it's that simple. But I think that's not going to happen right away. And
Mm,
in the interim, there's good news in that the use of clozapine is being made more routine and simplified.
mhm,
The regulatory stuff that was useful at the very beginning 60 years ago is no longer meaningful now.
mm,
So it'll be easier to use. I think we really have to train the generations of psychiatrists who've neglected learning about it.
mm,
And it shouldn't be that a psychiatrist feels comfortable seeing patients, especially severely ill patients,
mm.
without having the skill. And it's not like that difficult. It's not like a impossible
Exactly.
drug to use. It's just a little bit harder than some
Mhm.
of the others. And it's a function of laziness in part that people are not learning to use it. I'm going to have to stop now, though.
Okay. Well, thanks a lot, Dr. Francis. It was a pleasure, and have a good rest of your day.
Well, this was a great interview, and I've really enjoyed it. Thank you very much. And I think you're providing very valuable questions and I hope answers for your listeners.
Absolutely.